It's my pleasure to introduce Dr. Shannon Beres. Dr. Beres is a clinical assistant professor at Stanford. She is my partner in crime. She is both a pediatric neuro-ophthalmologist as well as adult neuro-ophthalmologist. And her expertise is really spanning the entire spectrum of optic disc drusen. So I'm really excited to introduce Dr. Shannon Beres. She's going to talk about pediatric optic disc drusen.
Great. Well, thank you very much, Joyce. Thank you, Stefan, for letting me be a part of this symposium today. Can you see my slides okay? Great. Excellent. So like Joyce said, I'm a pediatric neuro-ophthalmologist, and I'm here at Stanford. So the objectives today are going to be to recognize that pseudopapilledema and papilledema have some overlap and some distinct characteristics. And then to also recognize the importance of longitudinal studies starting in childhood, that we need to better understand the maturation of optic disc drusen. So this is a case of a 10-year-old who comes to me with headaches, and her complaint is essentially that she has headaches since the pandemic started. There was no prior eye exam and no vision complaints, but the mom notes that her brother wears glasses, so she wanted to make sure that she wanted to figure out if the headaches were actually due to need for glasses. So she came to a local optometrist. So the question is when they got there, there was concern for papilledema. Are we worried or are we not worried? Her vision was normal, 20/20 in both eyes, normal pressure, normal color. But this is what they found on the fundus exam. So the right eye here, you can see, has some elevated hyperemia, elevated disc borders, but the temporal border was clear and there's no obscuration of the vessels. On the left side, you can see the elevation, that's about 360 degrees, a little bit of a hyperemic disc and some obscuration of the vessels. So you put the kid on the Tour de France of the photo suite and they get a B scan and OCT, autofluorescence, and then a visual fields. And it's unclear as to which one of these tests are actually the most helpful for us to determine do we worry or not worry. This patient's OCT average RNFL was within somewhat normal, slightly elevated in the left eye. The visual field on the right side was pretty much normal, and the left side had a little bit of some temporal defects. So in pediatrics, we really have to think, am I missing the, a tumor? Am I the person who is going to be the one who sends for imaging in order to find something that we'd want to know about? So if we're worried, thank you. I'd wonder about that in the beginning, but you said things were good. So I was like, okay. Okay, so if we're not worried about the patient, then we end up waiting and watching, and we have them to come back the next 4 to 12 weeks for a follow-up. So she returns 4 months later, and her optic nerve, retinal nerve fiber layer thickness was elevated in both eyes. So I'm not exactly sure what to do. There's been a change over the last 4 months. There's a no symptomatic change. This is a problem we run into very often in pediatrics, papilledema or pseudopapilledema. As you can see in kids, there's growth of the nerve, there's changes on exam that we can follow over months to years. So it's something that we certainly need to come to a better conclusion as to what diagnostic tests can help us have a high sensitivity if this is going to be papilledema versus pseudopapilledema. So these variations in swelling in the young may be the reason why pseudopapilledema is such a conundrum diagnosis for us in the pediatric population. There's been a couple different studies that have looked at the different types of studies, which is the ultrasound, the OCT, autofluorescence, or fluorescein angiography, and to determine which one of these studies would be most helpful in this situation. Melinda Chang's group found that there was a misdiagnosis in using just one modality imaging kids in 2017. And then in 2020, Gia et al. Ended up finding that multiple modalities were needed. However, we made a little bit of an advancement. And just recently, Michael Wan's group from up in Toronto Sick Children's has suggested maybe OCT is all that we need. It is important that we rely on a test with high specificity for optic disc drusen, but we also need to make sure that there's high sensitivity for papilledema so that we do not miss papilledema. In Michael Wan's study, it looked at 41 children with optic disc drusen and 21 children with papilledema. Based on this cohort of children, the best diagnostic use of OCT was to actually assess for at least one of the following, which are these hyperreflective boot-shaped areas, a signal poor region, which you saw on the prior lecture by Dr. Hammond, which showed where the areas of the hypodense area was with reflective bands around it. Then the hyperreflective bands, as well in the hyperreflective bands. So those three things, if one of those were present, then there was a high specificity for this being optic disc drusen. He also looked to see if there was any of the angulation of the RPE in the Bruch's membrane. And although that was highly sensitive for papilledema, that was not specific for optic disc drusen. So what about these hyperreflective bands or lines? Can these help with pseudopapilledema versus papilledema? This is what you saw Dr. Hammond first talk about in the first lecture of today. And this is the Copenhagen Child Cohort 2000 eye study, which was 724 children. They looked at the OCT at ages 11 and 12, and then 5 years later at age 16 and 17. The optic disc drusen was found in 2.2% of the children, which was 16 children. And as you heard before, that in the children who there was development of optic disc drusen, there was typically hyperreflective lines that were seen before that. Other features that they found were the scleral canal in the optic disc drusen children did not change in diameter. But when they looked at a nested control of 115 kids, they noticed that the scleral canal did show some decrease in size. Then there was also the prelaminar hyperreflective lines that were seen in 100% of the kids with optic disc drusen, but they were also seen in about 3.4% of the nested controls. In addition, there was a hypermetropic direction of a refractive shift in children with optic disc drusen, whereas there was a myopic direction shift in the children without optic disc drusen. So as Dr. Hammond said, these hyperreflective lines are also seen in post-IIH papilledema patients and can be from the crowding of the axons in the scleral canal. So I don't think we can talk about crowding unless we actually get a good understanding of the anatomy that is rapidly changing in children. This is just a reminder of a slide that I went over last year that shows the normal growth of the eye in children. The optic nerve head in a 5 to 16-year-old, which was assessed by the Heidelberg OCT, found that the optic disc area and rim area have no difference in age or gender of the children. You can see the axial length here as it changes. The largest phase of change is between the ages of 5 to 13 years old. And then the optic disc and nerve growth, by about age 2, the child's optic nerve is about the size of an adult. So looking here is looking at a study in 1993 down at UCLA that looked at post-mortem postmortem autopsies of children's age 4 months to 21 years old. And they looked to see that actually the optic nerve growth is nearly the same as an adult by about the age of 2. So what about those FOMs that we've talked about already? What are they and how do they change in pseudopapilledema? Most recently, there has been a proposal that the material that makes up the FOMs is the cause of pseudopapilledema in kids who do not have optic disc drusen. As you heard from Dr. Hammond already, we know that from the adult studies, the optic disc drusen consortium studies have found that the FOMs are seen in many disorders, including papilledema, optic disc drusen, and tilted nerves. We saw from Dr. Wan's group in Canada that the FOMs were not sensitive for optic disc drusen in children. This is a retrospective study from 32 children in Israel that were referred for pseudopapilledema consecutively, and they found that the FOMs are the most common finding in pseudopapilledema without optic disc drusen. So they looked at both the findings of FOMs in children. It was 98.4% of children who had pseudopapilledema had FOMs, but only 20% of the children had optic disc drusen, which means about 80% of pseudopapilledema had FOMs. excuse me, 80% of papilledema were related to FOMS, but not the optic disc drusen. They also looked at these hyperreflective foci that we see within the FOMS and were found in about 94% of the patients with pseudopapilledema. In addition, they looked at ultrasound, and they found here this hyperechoic area that you can find here in children that do not have optic disc drusen, that they also find the same finding, but without the shadow that you can see typically on B-scan ultrasound with optic disc drusen. Excuse me. So here's our patient on the left. Prior studies have chronicled the appearance of visible optic disc drusen, and we have learned that the hyperreflective lines may be precursors to new drusen, and that FOMS are common in pseudopapilledema without optic disc drusen. More studies are needed to understand if my patient will truly be the patient who has only the growth of her drusen in her child and teen years, and then some stability afterwards, or will she be the one who will continue with progression? So what we need are longitudinal studies over time. And one thing that is missing in children is the ability to compare apples to apples. As you know, in children, we can use a handheld OCT early on, usually between the ages of anywhere from 0 up to about 5 years of age. And then after that, they can actually sit in the tabletop OCT where we can acquire EDI and OCTA. But handheld OCT has no automatic segmentation. It's a very steep learning curve, and it's not really generalizable because you need sedation and people need to learn how to use this. So we certainly do, moving forward, need to find some way to be able to really look at the characteristics of the optic nerve head here within the, and also within the scleral canal to better understand how these disc drusen grow with time and how they mature. And that hopefully will then help us get a determination of what test is best to determine pseudopapilledema versus papilledema. So the future goal here is going to be to find one thing that will be able to stop us from moving forward with the MRI, the lumbar punctures and labs that oftentimes we put these children through under sedation. So in summary, OCT EDI is now considered the new gold standard in adults and likely becoming the single most useful modality in children as the most recent study in 2021. And that innovation for imaging young children, optic nerves is going to be needed to start in early childhood and something that we can actually use along the growth of the child, and that will have reliability and being able to look at inner reliability between tests from one point time frame to the next time frame, even starting down in the young toddler years. All right, well, thank you very much. I'll pass it over to Dr. Liao for questions.
Thank you so much. In case some of you may not have heard, there's a quiz, a pop quiz at the end of the session, just to help you learn the key take points from each speaker. So you're seeing some cheat sheets from Dr. Beres there. Thank you for that fantastic talk. I have a quick question. Given the prevalence of ophthalmic condition, do you think it's feasible that one day it would just be like a school vision screening? You know, we would be imaging all kids?
Well, absolutely. And I think one, that would be a fantastic idea, but two, that's what we need now. We need that for the research in order for us to start understanding what changes happen in childhood. The Copenhagen group has done a fabulous job at taking essentially, almost 800 kids and just looking at 2 time frames of the imaging, and looking to see what the differences are. I mean, I think we would find so much more if we can start even earlier in childhood and just start imaging as many kids as we possibly can, especially if we can get these images fast, easy, and reliable.
We have a question from Dr. Chanda Elkins. The question is the headache in your patient. Dr. Elkins is wondering what's the cause of the headache.
Probably all the other reasons for headaches. I don't think it's related to the eyes.
It is funny how often people have headache and then somehow found themselves being diagnosed with optic disc drusen.
Yeah, very much selection bias, because they come to their optometrist, they look and they see that there's optic nerve elevation. And then the next immediate question is, oh, do you have headaches? And then of course the kid says, yeah, or yeah, he has been getting headaches. Oh, with the pandemic, he's been having more headaches, or he's on his screens too much, he's having more headaches. So I think it's a little bit of a selection bias, but also something to study.
Thank you. So in the interest of time, we're going to go on to the next speaker.